focused on mHSPC. So we are truly honored to have with us two distinguished academic leaders from premier government medical colleges in Tamil Nadu. First of all, it's my pleasure to introduce Dr. Prabhakar sir, professor and head of the department, Government Medical College, Coimbatore, and Dr. Satyamurthy sir, HOD, professor and Department of Government Medical College, Chennai Stanley. So Dr. Prabhakar sir is presenting Advancing mHSPC Treatment Horizons, Darolutamide without Chemotherapy, ARANOTE Evidences. Dr. Prabhakar sir, kindly proceed, sir. Thanks, yours.
Hello.
Yes, sir.
Are my slides visible?
Yes, sir. Visible, sir.
Okay.
Please make it in full screen mode, sir.
Now, can you see it?
It's not changed in full screen mode. Please make it full screen mode, sir.
Yeah, I have made it. Let me do it once again.
So kindly click that enable editing, sir.
Is it in full screen mode?
Not yet, sir. So kindly click that enable editing. After that, click the below button, sir. That one. That fourth one, sir.
No, it's not going back. Yeah, it's going back.
After that, below that fourth button, sir. Yeah.
Now?
Yes, sir.
Can you see full screen mode?
Yes, sir. Yes, sir.
Yeah.
Perfect.
Okay. Good evening to everyone. I like to tender my gratitude for Bayer for organizing this meeting and giving me this opportunity to talk about the advancing treatment horizons in the metastatic hormone-sensitive prostatic cancer. Actually, I'm going to talk about the role of darolutamide without chemotherapy along with ART, which is evidenced by the trial named the ARANOTE trial. This is my disclosures. So we all know the timeline for the management of prostatic cancer. The age-old treatment is the androgen deprivation therapy, which is formulated way back in 1940 by Charles Huggins, who has shown that removing the testis or giving estrogen controls the metastatic prostatic cancer for a certain period. That established that the prostatic cancer is a hormone-sensitive cancer. And the ADT rules the roster for almost 70 years, and we don't have much activity in the second decade of 21st century. After that, we have a flourish of movements from 2014 to 2024. In the last 10 years, we have seen many molecules coming and playing an important role in improving the prostatic cancer, both in the hormone sensitive as well as castration resistant setting. So in 2014 and 2015, through the Chartered trial and the Stampede Arm C trial, addition of chemotherapy, namely the docetaxel to the age-old ADT, has improved the outcomes. And later in 2017 and 18, the androgen receptor pathway inhibitors, namely the abiraterone, came into way through the study Latitude and the Stampede ARMG, which has established the role of abiraterone in addition to the androgen deprivation therapy. And in 2019, we have 3 trials, namely the ARCHES and ENZAMET, which has established the usefulness of enzalutamide, and Titan trial has reiterated the apalutamide role in the metastatic prostate cancer. In 2021, we have escalated the treatment to triple drug therapy with the help of PEACE-1 trial, where addition of abiraterone to the ADT plus docetaxel has improved the outcomes. And in 22, we have the new androgen receptor blocker, namely the darolutamide. In addition to the docetaxel and ADT, darolutamide has improved the outcomes based on the ARASENS trial. And in 2024, we have ARANOTE as well as ARASEC, which has established the importance of darolutamide in addition to ADT, which is found to be useful even in the absence of docetaxel. So despite the treatment with the ARPA and ADT or docetaxel plus ADT, a large portion of patients with metastatic HSPC will progress to CRPC within 3 years span. So we have an unmet need in our hands. The medical need remains for an efficacious treatment that offers a differentiated and improved safety profile for patients who are hormone-sensitive prostatic cancer, stage 4, without adding any significant toxicities and without having any drug-to-drug interactions. For that, we have ARASENS trial, which is a phase 3 trial. The darolutamide in combination with docetaxel has already shown the beneficiary effect in the metastatic HSPC settings. And based on this ARASENS trial, we have an approval in India for this drug in this setting in the year 2023. And darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic HSPC patients, as demonstrated in the global phase 3 study, namely the ARANOTE trial, and this ARANOTE trial, which have a significant Indian patients presence. So with the ARANOTE data, darolutamide has the potential to change the treatment paradigm, as now it will be the only androgen receptor inhibitor which could be used with or without chemotherapy. So the background of this ARANOTE trial is the darolutamide plus ADT with docetaxel is a standard of care for the metastatic HSPC. In ARASENS, darolutamide has proved the efficacy, and it proved it is safe to use darolutamide along with the dosi and ADT. And ARANOTE was designed to evaluate the darolutamide along with the ADT without the docetaxel. So this is the study design, which is a randomized, double-blind, placebo-controlled phase 3 trial, which included 665 patients who are hormone-sensitive prostatic cancer, which are metastatic, and histologically or cytologically confirmed adenocarcinoma of the prostate, which is a good performance status. And the stratification factors include presence or absence of visceral metastasis and prior local therapy given or not. So the subjects are randomized in 2:1 patient to either darolutamide 600 milligram twice daily along with the androgen deprivation therapy or placebo plus ADT. And the primary endpoint being the radiological progression-free survival. And we have a plethora of secondary endpoints, namely the overall survival, time to initiation of subsequent anti-neoplastic therapy, time to CRPC, time to PSA progression, rates of undetectable PSA, that is below 0.2 nanogram per ml, and time to progression and safety. These are the key secondary endpoints. And the other pre-specified endpoints include PFS2, time to symptomatic skeletal events, and time to deterioration of FACT-P total, and time to first prostatic cancer-related invasive procedures. So these are 2 phases, namely the double-blind phase, and this is an open label phase. In the open label phase, the patient has received darolutamide, and those who are on the control arm or placebo arm, if they are progressors, or 100% crossed over to the open label darolutamide. And the endpoints for this open label phase is the overall survival as well as the safety. So the data cutoff for the ARANOTE trial is the 7th of June 2024. And the median follow-up duration for darolutamide group, it is 25.3 months, and for placebo group, it is 25 months. So the subgroup, it is the basic characters are evenly matched. You have to look at the percentage. Since it is a 2:1 randomization, look at the percentage. They are all the subgroups are evenly distributed in both the darolutamide arm as well as the placebo arm. And the randomization is based on the race, which includes the white, Asian, black, and others also. And the region-wise also, it has been subclassified as Asian population, Latin American, Europe, and the rest of the world population. And the Gleason score 8 or above also has been taken into granted. And the medium serum PSA level is 21.4 for darolutamide and 21.2 for the placebo arm. And the stratification is based on the disease volume, high as well as low, presence or absence of visceral metastasis, prior local therapy. These are the subgroups. So if you look at the other trials, namely the COU-302 trial, in which the abiraterone or recent trial, in which the lutetium-177, as well as the EMBAR trial, in which the enzalutamide has been tried, you can see in this map clearly that in all these three trials, the Asia as well as the Africa are conveniently left out. Only the Asia, Australia has been included in the abiraterone as well as in the enzalutamide trial. But you look at the ARANOTE trial, it is a true global trial in which the North America, South America, Asia, and Asia Pacific as well as Africa have their representation in this trial. If you look at the Asia Pacific region, though many of the trials say Asians, they may not include India because we are delicately posed in a way, we are neither Asians nor true Caucasians. So most of the trials will not include Indians, but in this Asia Pacific subgroup, we can see India has been represented well at the rate of 13.7%, and China is highest, having 14.6%. The other populations include Taiwan, Australia, and New Zealand. So look at the primary endpoint of the radiological progression-free survival. You look at the Kaplan-Meier curves are widely separating right from the beginning. And if you look at the end of 24 months, the rate of progression-free, 70.3% of the darolutamide patients remained radiologically progression-free, whereas the placebo only 52% remained progression-free. If you look at the median RPFS, it is 25 months for the placebo arm, whereas for darolutamide, it has not yet reached. It translates into a hazard ratio of 0.54. There is a 46% reduction in the progression to radiological failure. Look at the forest plot. You can see all the subgroups are benefited with the help of darolutamide, be it the, like I said, the Asian population, as well as the patient who are having high or low volume disease, European or non-European, those who are having visceral metastasis or not, those who have received prior therapy or not, all have been benefited with the addition of darolutamide to the ADT. So the benefit has been seen in the across all the secondary endpoints: the overall survival, the time to progression to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy, and time to pain progression. You can see all are on the left side of this graph favoring the darolutamide. So at the time of primary analysis, OS data are immature. Since the OS is immature, patient will be followed until the patients are surviving. So all the remaining per protocol placebo patients offered crossover to darolutamide after the primary analysis. So if you look at the time to progression to metastatic CRPC, you can see the medium time to mCPRC is 13.8 months for placebo arm, whereas it has not yet reached in the darolutamide arm. If you look at the hazard ratio, it is 0.4, there's a 60% delay in the progression. If you look at the progression of pain, you can see the median pain progression is 29.9 months, nearly 30 months for the placebo, whereas it has not yet reached in darolutamide arm with a hazard ratio of 0.72. So the delays in time to progression can be of high importance to patients and have not been demonstrated with other androgen receptor inhibitors till date. Look at the PSA response, it is very deep as well as very durable. If you look at the cutoff value of PSA less than 0.2 nanogram per ml at any time during treatment, you can see it with the darolutamide arm in the overall population, around more than 60% of the patient have shown PSA value below 0.2 nanogram per ml, compared to less than 20% in placebo arm. And time to PSA progression, you can say the median for placebo is 16.8 months, whereas it has not yet reached in the darolutamide arm with a hazard ratio of 0.31. That means there is a 79% improvement in the PSA control. So this darolutamide has been found to be useful in high volume as well as in low volume disease. Those who are having high volume disease, based on the chartered trial, the PSA response is achieved in around 44.1% within 24 weeks, compared to only 10.8% in control arm. And at the end of 48 weeks, it is 50% achieved the PSA level of less than 0.2 with the darolutamide, as against only 14.2% with the control arm. At any time, the percentage of patients who are having PSA less than 0.2 is around 54.6%. Same thing if the patient is having a low volume, then the PSA fall is seen in around 72% within 24 weeks. At the end of 48 weeks, it is nearly 80%. At any time, the PSA is under control with the help of darolutamide in around 82.6% of patients, compared to only 25% of the patient in the placebo arm. The progression to subsequent life-prolonging anti-cancer therapy, you can see only around 32.5% required subsequent anti-neoplastic therapy, compared to around 42% those who received only placebo. The common subsequent systemic therapies include, the common one is the docetaxel and the other is the abiraterone, which is in 22.7% and 12.8% respectively. The other agents like enzalutamide, apalutamide, cabazitaxel, radium, as well as olaparib has been tried, which constitute lesser percentage. See, come to the treatment emergent adverse events. You can see it's a very safe drug, darolutamide, in addition to the ADT. If you look at the any adverse events, it is seen in around 91 patients. So not much higher than what is seen in the placebo, which lies at the 90%. The grade 3 or 4 adverse events is seen in around 30.8 in darolutamide arm, which is equal to that of the placebo, which is 30.3%. And grade 5 adverse events also similar between the both arms. And serious adverse events also is similar. And if you look at the discontinuation rate because of the adverse events, it is less in darolutamide arm compared to placebo. That is 6.1% versus 9%. So the median treatment duration with the darolutamide is 24.2 months compared to 17.3 months with the placebo arm, which shows the darolutamide has been well tolerated. And the safety profile of the darolutamide in ARANOTE was independent of PSA response, and it is consistent with favorable tolerability, first, which is seen in the ARAMIS as well as in the ARASENS trial. If you look at the most common adverse events, they are either similar or seen low compared to the placebo. Only thing which is slightly higher is the insomnia as well as the hyperglycemia. The other parameters are equal. The parameters which are seen less are the bone pain, fatigue, as well as increased creatinine level are seen less in the darolutamide arm compared to the placebo arm. And the rates of adverse events commonly associated with ARPI were similar across all treatments. If you take any of the events, is the percentage, and this is the exposure adjusted incidence rate. You can see whatever may be the side effects: hypertension, vasodilatation, diabetes, cardiac arrhythmias, fatigue, rash, coronary artery disease. All are similar between both the arms, which shows darolutamide does not produce any increase in the adverse events. If you look at the quality of life, HRQOL, which was presented in the ASCO 2025, the darolutamide extended the medium time to deterioration of the FACT-P total score is 5.1 months versus placebo. So there is a 5.1 month improvements with the help of darolutamide. And darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delay in the pain progression as well as the overall well-being. Look at the time to deterioration of FACT-P total score. It is 11.5 months in placebo arms, whereas it is 16.6 months with the darolutamide arm. So it has a hazard ratio of 0.76. So the other parameters like the social well-being, emotional well-being, functional well-being, and bowel symptoms, urinary symptoms, all are better with the help of better in the darolutamide arm rather than the placebo arm. So to conclude, darolutamide with the addition of androgen deprivation therapy significantly improves the radiological progression-free survival in patients with the metastatic hormone-sensitive prostatic cancer. And the darolutamide has showed benefit across all secondary endpoints. It is associated with a deep as well as a durable PSA response, regardless of the initial PSA level. And it is the first and only androgen receptor to demonstrate clinically meaningful delays in the pain progression, overall well-being, including the social, functional, and urinary symptoms. And it has a very favorable safety profile also. So with this ARANOTE trial, and darolutamide along with ADT has become an additional standard of care for patients with metastatic hormone-sensitive prostatic cancer who are elderly, having comorbidity, having poor performance status, and they're not fit for docetaxel. We have the option of giving just darolutamide along with the ADT. With that, in my talk, I thank once again Bayer for this opportunity and all the participants for your patient listening. Thank you.
Thank you, Doctor. Thank you very much for sharing your deep insights on ARANOTE evidence, sir. Now I welcome Dr. Satyamurthy, sir, to present the reaching newer heights in mHSPC care. I will just share the slides, sir. Just hold a second, sir.
Thank you, Dr. Prabhakar, sir, for highlighting about the role of darolutamide without chemotherapy along with ADT, the benefit of radiological progression-free survival and overall survival benefit in patients with metastatic hormone-sensitive prostate cancer. I'm going to talk about how to approach metastatic hormone receptor positive, hormone sensitive prostate cancer. Next slide. Disclaimer. Next. Yes. In prostate cancer, most of the patients are present with metastatic disease. So metastatic hormone sensitive prostate cancer may progress to castrate resistant prostate cancer. Initially, they will be either localized or metastatic disease. Very rarely they CRPC. So our aim, one point of time, at least 3 years time, the patient may progress to metastatic castrate-resistant prostate cancer. Our aim is to delay that. Normally, the localized disease, the 5-year survival of prostate cancer, it is around 99%. But in metastatic disease, 5-year survival, it is only 27%. Even if it is crossed to the metastatic castrate-resistant prostate cancer, the survival is only 25 months. So in prostate management, cancer management, our aim to delay the patient to enter into the metastatic CRPC. That is our aim. So how to achieve this? By local radiation or adding chemotherapy along with ADT, ADT alone, ADT plus chemotherapy, ADT plus radiotherapy, ADT plus androgen receptor signaling agents. This is the way we can delay the patient from metastatic hormone sensitive to the metastatic castrate resistant prostate cancer. Next slide. Next slide.
I think it's not 1 minute, sir. Is it okay, sir?
It's also same. Next. Yes. As I told, our target is to delay the metastatic castrate resistant prostate cancer. Next. So various trials are involved in the how to treat. Already, sir, Prabhakar sir highlighted how from the 1940 it is only bilateral orchidectomy. So next 5 decades there is no trials. After the 1990, the various drugs were used to delay the castrate to prolong the castration sensitivity. Okay. Important trial is Stampede trials. The Stampede trial has many arms. Control arm is ADT alone and ADT plus docetaxel, ADT plus abiraterone, ADT plus radiotherapy, and various arms are there in the Stampede trial. Each arm, the results are published in various years, and the idea is ADT alone is not sufficient. ADT plus other combination will definitely prolong the survival and delays the castrate resistant to delay the to jump to the castrate resistant stage. Next slide. So it is what is the role of radiotherapy in prostate cancer, especially in metastatic setting? So radiotherapy, there are 2 or 3 trials in the radiotherapy role. One is a Stampede trial. Another is ARANOTE trial. So these trials have given the mixed results. So the outcome of this trial analyzed in meta-analysis, like in 2021, there is a meta-analysis of stopgap meta-analysis was published. The outcome is radiotherapy does not improve the overall survival when you add it to the ADT, but it has a significant benefit in biochemical progression-free survival and failure-free survival among the low burden disease, not in the high volume disease. So radiotherapy role is mainly in the low volume disease. It won't give a benefit of overall survival. This is the outcome of stopgap meta-analysis published in 2021. Next slide. This chart shows various trials from the 2013 to 2022, which used chemotherapy, ADT plus chemotherapy like docetaxel, and ADT plus abiraterone, the 17-alpha hydroxylase enzyme inhibitor, and ADT plus various antigen receptor signal inhibitor like enzalutamide, apalutamide, and darolutamide. We know the wealth of data supporting for concomitant therapy, and how to choose all, as the hazard ratio is around 0.65. That means there is a reduction of 35% of reduction in the death. So most of the combinations have hazard ratio of 0.65. Next. So how to choose? The selection of the combination is based on the side effects. First, we'll go to the charted trial. This is one of the landmark trial in metastatic hormone-sensitive prostate cancer. First time, ADT plus docetaxel improved the overall survival. That benefit is shown in the high volume disease. That is, the OS benefit is 16.8 months, but in low volume, this is not achieved. So in all high volume disease, the docetaxel to be added with ADT. What is how will you define high volume disease? The high volume disease is mentioned as presence of visceral metastasis or more than bone 4 bone metastasis, 4 or more bone metastasis with one or more outside the vertebral column and the pelvis. This is the definition given by the charted trial. They divide into high volume and low volume. So docetaxel has a benefit in the high volume disease, not in the low volume disease. Next slide. And latitude trial, especially abiraterone in the high risk metastatic hormone receptor hormone sensitive prostate cancer. What is the meaning of high risk? Here also the high risk is 2 or more factors. If it is there, that is high risk. The factor 1 is presence of visceral metastasis or Gleason score 8 or more than 3 bone lesion, 3 or more bone metastasis. This is the high risk factors. If it is 2 or more is present, we consider as a high risk disease. In this study, abiraterone with ADT has benefit. It improves the overall survival and reduces the hazard ratio is also 0.65. That is the 35% reduction of the death is proved. So first hormonal therapy, which has a benefit, is abiraterone, that is proved by the latitude trial. This is also confirmed by the one of the harm by Stampede trial. So the main side effects of abiraterone is hypokalemia and hypertensions. Whenever patients, if you prescribe these patients, so we have to check for frequently we'll check for hypertension and monitor the potassium level. Next. As I told, usually you will prescribe prednisolone along with the abiraterone. The grade 3 and grade 4 toxicity, if you see, the hypertension is more, grade 3 hypertension is more, that is 22% compared with ADT alone, ADT plus placebo alone. So we have to monitor the blood pressure periodically for a patient on abiraterone. Next slide. Yes. Another androgen receptor signaling pathway drug is apalutamide. So this Titan trial proved there is a benefit with when I add with ADT. Here also the benefit is more seen in the high volume disease, and the hazard ratio is 0.53, and low volume disease the hazard ratio is 0.36. The overall survival benefit, the hazard ratio is 0.65, and progression free survival also is 0.48. It is proved that it is a best combination with the ADT, but the side effects of apalutamide is some rashes, and seizures risk is more common. So if patient have any history of epilepsy or elderly patient have a neurocognitive dysfunction, we cannot prescribe apalutamide. Next. Next is enzalutamide. Two trials are there for enzalutamide, mainly enzalutamide trial, which has ADT with enzalutamide has a survival benefit both in the low volume and high volume disease. Here also the enzalutamide has a side effects among the all ARSI drugs, androgen receptor signaling inhibitors. The most toxicity will be there in the enzalutamide. Okay, next we'll proceed to the combination therapies, especially triplet trials. The phase 1 trial is an important triplet trial, ADT, docetaxel plus abiraterone in one arm, ADT plus docetaxel is another arm. So this trial proved, especially in hormone sensitive metastatic prostate cancer, it has overall survival benefit, become the standard of care in 2020-21. Next. Yes. Here also you see that the Kaplan-Meier curve in a high volume disease and low volume disease. In high volume disease, there is a significant separation is there, but in the low volume disease, the benefit is minimal. So any patient with high volume disease, triplet combinations become the standard of care after the results of phase 1 trial. Next. Another important triplet trial is ARANOTE trial. Here, ADT, docetaxel with the darolutamide versus ADT plus docetaxel alone is challenged. The primary endpoint of this trial is overall survival benefit, and the secondary endpoints are time to castration-resistant prostate cancer, time to change to the castrate-resistant phase, and time to pain progression, and improvement in the symptomatic skeletal related events, and time to progression to the symptomatic skeletal events, time to initiation of the subsequent antineoplastic therapy, and time to worsening of the physical symptoms. These are the secondary endpoints. Next slide. In overall survival, this Kaplan survival curve shows at 50 months, there is a survival is 63% with adding darolutamide with along with ADT plus docetaxel. In ADT plus docetaxel alone, it is 50%. The hazard ratio is 0.68. That is 32% of reduction of risk was achieved by adding the darolutamide along with ADT with docetaxel. This is another landmark triplet trial become the standard of care, especially patient with high volume disease. Next slide. Here, high risk and low risk patients. Both the patient has a benefit with the triplet therapy when adding with darolutamide along with ADT with docetaxel. The secondary endpoints, time to progression to the castrate-resistant prostate cancer, it is significantly delayed while adding the darolutamide compared with placebo. There is a 64% reduction based on the hazard ratio of 0.36. And time to pain progression, another secondary endpoint also is better with darolutamide with ADT with docetaxel. And time to first subsequent antineoplastic drug also is delayed while adding the darolutamide, and these are the secondary endpoints. Also is not only the primary endpoint of OS, irrespective of the high volume and low volume disease, and the secondary endpoints also achieved by this triplet combination. Next. This is the PSA response. At 24 weeks, 47.7% are achieved less than 0.2 PSA level. Compare with ADT and docetaxel, it is only 23.9. At any time, triplet had undetectable PSA at 67% patient achieved undetectable PSA. Compare with ADT with the docetaxel is only 28% of the patient achieved undetectable PSA. This is another secondary endpoint. This is showed by the Kaplan survival curve also. Okay, next. This is also same. It shows darolutamide triplet achieved a long period of PSA control. Same, it indicates that darolutamide delayed the progression. So the advantage of darolutamide is the side effect profile is very safe. The CNS penetration is very less. So we can use patient with seizures, other CNS neurocognitive function is affected patients also. We can use darolutamide either with a triplet combination or ADT plus darolutamide alone as per the ARANOTE trial. So it has a deeper and durable response compared with other drugs like apalutamide, enzalutamide, and abiraterone. So it's become the standard of care. So best side effect profile is there with the darolutamide. Thank you.
Thank you, doctor. Thank you very much. Thank you, sir. Thank you very much for giving your deep insights on the newer therapies for mHSPC. Sir, there is one question, sir.
Yes.
In high volume mHSPC, do you routinely prefer triplet therapy based on the data for us in trial, or are there any other situations where do you would consider doublet therapy?
High volume disease, if patient performance status is good, we'll go for triplet therapy. Patient not able to tolerate docetaxel will go for only ADT plus darolutamide alone. That is my opinion based on the data.
Thank you, sir. Thank you, sir. Thank you for giving your deep insights, sir. Once again, sir, sir, from organizing team, we are deeply thankful to Dr. Prabhakar sir and Dr. Satyamurthy sir once again. And thank you very much for the audiences who are there in the line for as your busy schedule. Once again, thank you, sir. Thank you very much for joining the meeting, sir. Thank you, sir.
Thank you.
Thank
Bye.
you. Thank you.
Thank you.
Thank you. Bye.
Thank you, Doctor. Thank you, Doctor. Thank you very much, sir. Tech team, kindly close the meeting. Tech team, are you there? Tech team? Tech team? Technical support team? Can you hear me? Tech support team? Tech support team, are you there? Tech support team? Satyamurthy sir, you can leave the meeting, no issue, sir.
Oh, thank you.
Thank you, sir. Thank you. Tech support team?
Yes, sir.
Yeah, please close the meeting.
Okay, thank you, sir.
Thank you.